Hi, good afternoon, everyone. Thanks for joining us today. My name is Lori Smetanka, and I'm the Executive Director of the Consumer Voice, and we're glad to have you join us for the next installment of our webinar series, COVID-19, Advocating for Nursing Home Residents, sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. Through these webinars, we've been working to keep you updated on the latest information, guidance, and actions at the state and federal levels related to COVID-19, and also to talk about the impact on residents of long-term care facilities, share resources, and offer recommendations for advocacy. Next slide, please. We have a very full agenda for you today. We're going to hear about new guidance issued from CMS just yesterday on the reporting of staffing data, which has been suspended for the last couple of months. We're also going to talk about comments that are due on interim regulations around reporting requirements. They're due in early July. And then we're going to talk about the issue of reuniting residents and families from a couple different perspectives today. Next slide, please. So our speakers today are going to include Richard Mollett from the Long-Term Care Community Coalition, Robin Grant and myself from the Consumer Voice, Beverly Laubert, the State Ombudsman from Ohio, Suzanne Messenger, the State Ombudsman for West Virginia, and Mike Dark, who is from California Advocates for Nursing Home Reform. A reminder that today's webinar is being recorded. The recording and slides will be emailed out to all participants next week and will be posted on the Consumer Voice website. You can also find the recordings and slides from previous webinars on the Consumer Voice's website, and today's slides can be downloaded from the chat box. We'll be putting a link to that in there in just a moment. All lines will be muted throughout the webinar, so please post your questions for presenters in the Q&A box on your control panel. Use the chat to make any comments or discuss points among yourselves. And after the presentations, we will get to as many questions as we can. And with that, without further ado, I'm going to turn it over to Richard so we could get started with presentations today. Richard?
Thanks, Lori. Appreciate it. I'm Richard Mollett with the Long-Term Care Community Coalition again, and I'm going to talk about some of the changes that CMS announced just yesterday afternoon to the star rating system and reporting of staffing levels and quality measures on Nursing Home Compare. Next slide, please. So I thought I'd start with a brief background. This is a picture of what Nursing Home Compare looks like. It's medicare.gov/Nursing Home Compare. If you just do a search for Nursing Home Compare, they'll take you to that as well. And as you see here, you can type in city or state, and then you can even type in the name of a nursing home or just do a search and get down to either a single nursing home or nursing homes in your state or in your city or community. So the Nursing Home Compare and the 5-star quality system, which is a component of Nursing Home Compare, they provide information on every licensed facility, every facility that's certified under Medicare and or Medicaid in the United States. A lot of people, sometimes criticize Nursing Home Compare. It's not perfect, but it is by far the best, most accurate and complete information that we have about nursing homes in this country, but either on a state or federal level. Now, every state also has its own version of Nursing Home Compare, which it's really up to the states what they want to put out, although there are certain essential things that CMS requires that the states have. I generally prefer Nursing Home Compare. It's just, it's a good place to go for information, especially with the 5-star rating system. It makes it very helpful. So the star ratings, every nursing home has an overall star rating, and that overall star rating is based upon 3 key indicators. The first one being survey results, their inspections. The second one being staffing levels, the staffing levels for the nursing home, for the nurses, RNs, LPNs, and CNAs. And then lastly, based on what are called quality measures, excuse me, which is the essentially based upon the information from the minimum data set, the assessments that are done on residents from whether they become more depressed to whether they need help with toileting, whether they're on antipsychotic drugs. There's a range of them, and there are, I believe, 15 that are of those measures that are used for the star rating in Nursing Home Compare. Next slide, please. So there have been some changes that were initiated early in March in response to the COVID-19 pandemic. Essentially what CMS, the Centers for Medicare and Medicaid Services, did was they relieved nursing homes of a variety of different reporting requirements during the period of the pandemic. And we all those of us who are hosting this program have been very concerned that for a number of reasons. One is because this information, for instance, on staffing is really important. Information on those quality measures that we talked about just a moment ago, they are somewhat valuable. Staffing, of course, is from our perspective the most important of the data provided on Nursing Home Compare. And so the CMS told facilities that they did not have to report that information for the time of the pandemic. So there's been a couple of months now where they have not been required to report. In addition, CMS also waived requirements around regular inspections and complaint investigations. They are now taking place, as I'm sure many of you know, on a far more limited basis. They've also reduced minimum staff training and certification requirements for care staff. I think perhaps most importantly is in regard to the certified nurse aides who provide most resident bedside care, that the requirements for 75 hours or more of certification training have been waived for the course of the pandemic and continue to be waived. They also waived the 30-day notice for facility-initiated transfer. I think we've spoken about some of these, and particularly that one in prior programs. So up until the pandemic, nursing homes had to provide a 30-day notice for a transfer, and the resident had the right to appeal. During the pandemic, CMS said that you can transfer a resident without even a day's notice, essentially. So yesterday, again, June 25th, so it was literally yesterday afternoon, CMS announced the resumption of reporting requirements, the number 4 that I mentioned above, the daily staffing levels, and the minimum data set, so-called quality measures. So I took the following points directly from CMS just to make sure that they were clear and accurate. And as you can see at the bottom of this slide, I have the link to the CMS file. Facilities must now submit staffing data for 2020 second quarter by August 14th. Facilities may, but are not required to submit for 2020 first quarter. So just to be clear, they are not required to report for January, February, or March their daily payroll-based journal staffing levels. They will be required for April, May, and June, and they have to report that by August 14th. Nursing Home Compare staffing measures and ratings will be updated by CMS on Nursing Home Compare again on October 2020. Beginning this July 29th, quality measures based on data collection period ending December 31st, 2019 will be held constant. These last 2 points, this point and the next one, are a little bit more in the weeds, but I just wanted to give you, this may not be, in other words, this may not be information that's particularly relevant to everybody, but I wanted to at least provide that. So just to quickly backtrack, the rating system, as I mentioned earlier on, the 5-star ratings are based upon these different indicators, the so-called quality measures, staffing, and inspection results. And so what CMS is saying here is that they're going to hold the quality measure rating constant based on data collection period ending December 31st, 2019. However, they are not holding quality measure ratings constant, as a facility's quality measure rating can still be updated by a quality measure with underlying data that is earlier than December 31st, 2019. I had to read that a couple of times to get a grasp on it. So not necessarily something we have to memorize, but I just want to clue in, because I know I do speak to people, especially ombudsmen and advocates who ask questions about the data, why data haven't changed when things have changed in the facility. So I just wanted to give that background. Next slide, please. So I wanted to end with some of our perspectives and concerns. One, we are really glad to hear that the requirement will be reinstated. We have been so concerned during this time when residents are more vulnerable than ever. And we know that there are issues with staff coming down with the coronavirus, staff having to stay home because they have other illnesses or they have family members for whom they have to provide care, that we've been really concerned what is going on in nursing homes. As you all know, there haven't been family visitors or ombudsman visitors for several months now. So I think it is so important for us to have information, to have good data on what's going on, what has gone on, what the staffing levels have been, what even some of those quality measures, which I don't love, they're not all that great, but some of them are useful, what they are saying about the care during this time period. And it's very alarming that for at least the first part of the pandemic, we won't possibly ever have that information. CMS is not planning on asking the facilities to ever report the payroll-based journal data from January through March. So we're really glad that the reporting will start for the April, May, June period, that the second quarter of the year, but however, still concerned about the lack of reporting for the first months. In addition to, I just want to lastly point out, in addition to our concerns about finding out what has gone on during this period, I mean, that's really important. We want a record of what has happened to residents. We want to know. I mean, I think that's just important for the residents who have suffered and the residents who have died at this time period. But I would say, as importantly, how are we ever going to know how to address a second wave or a future pandemic or a future emergency if we can't look back and accurately get an idea of what is going on or what has transpired during the months of the pandemic? So that's a real concern. In addition, lastly, I just wanted to mention, as I had said at the very start, there were other things that CMS has waived during the pandemic, and those things continue to be waived. So we're all very concerned, as you know, as was discussed today, about the blockade on family and ombudsman visitation to nursing homes, which is starting to be relaxed. We're very concerned about the continued absence of regular surveys and complaint investigations by the states. That's still a federal directive not to conduct those regular surveys and complaint investigations, about relaxed staff certification requirements. As I mentioned before, that CMS has said that nursing homes can have nurse aides working in the building without having passed or passed a certification class. And then also, of course, the freedom to discharge residents without notice or due process. As I mentioned earlier, we're very concerned that these things are continuing, and we will certainly be engaging CMS and getting back to you all in terms of going forward. Next slide, please, excuse me. I just wanted to mention at the very end, our website, nursingHome411.org, we do have we just put this out actually about 2 weeks ago, I guess. You can see with the arrow, the nursing home staffing data for the last quarter of 2019. So there's always a lag time. We're just gonna, again, miss the first quarter of this year, perhaps permanently, but we just released the data for the last quarter of 2019. What we do is, CMS requires that nursing homes report their payroll-based staffing data for every single day of the quarter when they put in those reports. What we do is we average them out for the quarter for every facility in the country that has reported data, which is the vast majority of them now. And we break that up into searchable state files. So you can search for your nursing home, you can search for nursing homes in your county or in your city or by zip code and compare them, et cetera, in regard to staffing. So that information is there. And of course, we have some other, as I note here, some other facility level and state level COVID-19 data, which we have been updating. But the staffing data, I especially wanted to mention because past is prologue. I mean, we know about what a facility is going to do going forward from what it did in the past. And I think knowing if a facility didn't have enough staffing in the last quarter of 2014 will give you a good idea, absent more current information, how it's doing now in terms of its staffing. So thanks very much. I'm going to pass it on to Robin.
Thanks so much, Richard. So I'm going to talk about commenting on the interim rule that has to do with reporting about COVID. So you may remember that on May 8th, CMS released an interim rule with comment for nursing home reporting of COVID data. The rule was effective right away, but CMS gave the public until July 7th to submit comments. So today, we just want to share with you very briefly what the rule requires, what changes we believe should be made, and how all of you can take action related to the comments. Next slide, please. So you can see on this slide the actual rule. We've discussed what the rule requires on previous webinars, so I'm not going to go into detail here, but let me just say that there are kind of essentially two sets of reporting requirements for nursing homes. The first set of requirements mandates that nursing homes electronically report certain data to the CDC weekly, and you can see that data in G1. The second set of requirements mandates that facilities report specific information to residents, their representatives, and their families within specific timeframes. And you see that in 3. So at Consumer Voice, we've reviewed and analyzed the interim rule, and we'd like to highlight some of the key changes that we believe should be made. Next slide, please. So first, we think there's additional information that should be collected. I'm just going to hit some highlights here because I don't have time to go through and list everything that we believe should be changed. But in terms of additional information, we think it's absolutely essential that demographic information be obtained, and that needs to include, among other things, race and ethnicity. I mean, we absolutely have to have that data so we can look at and hopefully address disparities that we know we are seeing in COVID infections and deaths. We believe that CMS also needs to be collecting the number of residents and staff who recovered from COVID and those who were hospitalized for COVID as well. We also think that facilities should be required to report actual nurse staffing levels. What they're required to report now is staffing shortages, so that's their opinion of whether they're short-staffed or not. But we believe that the actual nurse staffing levels need to be reported. And then much more specific data about testing really needs to be collected. The regulation just does not go into detail about what information related to testing needs to be collected, and that needs to be remedied. Second, we think that certain information in the rule needs to be defined or clarified. So just as an example, we think the rule needs to define what's considered to be a suspected case. There's no definition anywhere in the rule about what that is. And another example is the rule should lay out what specific types of PPE facilities have. It just talks about PPE broadly, but not what types. And certain information also needs to be simplified. I think one of the best examples of the need for simplification is that residents, their representatives, and their families are supposed to be notified when there are 3 or more residents or staff with new onset of respiratory symptoms occurring within 72 hours of each other. I mean, this, I've had to read this so many times in order to really kind of understand it, and I think that this can be expressed much more simply. And in fact, we actually think that what they're saying here is suspected cases. And that's the language that should be used. Next slide, please. So there are also kind of a number of major revisions that we're calling for. We think that the same comprehensive information needs to be provided to everyone. So right now there's some information that goes to families and residents and their representatives, and other information that goes to CDC. We think that there should be just one set of information that goes to everyone. So by information, we mean all the information, the number of suspected cases, confirmed cases, deaths, PPE, staffing, and so on. And by everyone, we mean agencies and programs. So that's not just CDC, but we would add CMS, the State Survey Agency, the State Ombudsman Program, and the Protection and Advocacy Agency. And that means residents, their representatives, their families, and staff. We really believe that staff have the right and need to have this information because they are working in an environment that may have the virus. They need to know if the virus is there, its status. So staff should be included as well. And we absolutely believe that residents and their representatives and families deserve to know everything. You know, it's their or their loved one's home. It's their or their loved ones' lives that are at stake. And frankly, it's public information. The information that nursing homes are being required to submit to CDC goes to CMS and then is posted publicly. So it's public information. Let's just give it to everybody. We also think that it should be given, reported daily. You know, weekly, from our perspective, is not enough. You know, we're in a public health emergency where everything is changing incredibly rapidly. So information is needed for decision making and responding rapidly to the virus. And I would also add, daily is actually what is recommended by the CDC. We're also recommending, and this would be new, that facilities report on a standardized form to residents, their representatives, and families. I mean, that way the information is uniform and consistent. We also want this information to be easy for residents, their representatives, and families and staff, that's quite a mouthful, to obtain. So that would be, from our perspective, our recommendation would be that for residents, it's provided to them orally and in writing. And for others, it could be by email, website postings, recorded telephone messages, in other ways. The rule does not talk at all about how this information is to be disseminated. We think that that is a problem and that needs to be addressed. We also believe that reporting must be retroactive to January 1st. You heard Richard talk about what a problem it is that we will be missing 3 months of staffing data. Well, the interim rule for reporting went into effect May 8th. And CMS says to facilities, you can choose to provide data going back to January 1st, but you don't have to. And that's a problem. Some facilities are reporting it, some aren't. But if we're going to know what was happening in facilities since the pandemic began, we have to have this information going back to the beginning of January. And let me just give you one example of why it's so important. You all, I'm sure, remember Life Care Center in Kirkland, Washington. So that was the first nursing home that reported a large-scale outbreak. So there were 45 deaths at this nursing home earlier this year. But because they don't have to report back to January 1st, if you look at their data right now, you're going to see 0 deaths. Now that is not an accurate picture of the impact of COVID-19. So we think that all facilities should be required to provide that retroactive information. And lastly, we believe that the reporting requirements really should be expanded to other institutions and congregate settings, such as Medicaid-funded congregate settings, such as group homes and assisted living facilities, intermediate care facilities for individuals with intellectual disabilities, institutions for mental disease, and that's just to name a few, because that information is really critical for protecting everyone, and really shouldn't just be limited to nursing homes. Next slide, please. And now for, from our perspective, the most important part, which is what advocacy action all of you can take. Not only have we at Consumer Voice analyzed the regs, we've prepared written comments that we will be submitting, and we want to now urge all of you to submit comments as well. To help you with that, on Monday, we're going to be sending out an action alert, and we're going to provide you with key points that you can include in your comments. We're going to give you a link to our comments. So we're going to post our extensive set of comments, and we encourage you to shamelessly pull, borrow, steal, whatever word you want to use. Take anything you want from our comments. And we're also going to give you information about where to submit comments and how to go about doing that. So in closing, I just want to say that we really hope that you will all provide comments on behalf of your organization, if you're with an organization or a program, or on behalf of yourself as an individual. I think we all need to send a message to CMS that, you know, these rules on reporting are important. They're necessary, but they do need to be improved and strengthened, because we absolutely have to have more information and better information to guide us in our actions right now to contain the virus, but also to understand how we can make our responses, as Richard said, to the second wave or to future pandemics more effective. So that we can truly learn from this and do better, much better by residents in the future. So with that, I'll turn things back over to Lori.
Okay, thanks Robin and Richard for your presentations. We're going to talk a little bit and hear a little bit more about what's going on with respect to reuniting residents and families. That is probably the biggest issue right now that we have been hearing about, and one where we are starting to, not starting, but have been doing a lot of advocacy, and we know a lot of work is being done at the state level as well around this issue. So we're going to hear from two state ombudsmen who are going to just give us a very brief overview of what's happening in their states, and then we will go over the new frequently asked questions that CMS issued just earlier this week. So with that, I'm going to turn it over to Beverly Laubert, who's the state ombudsman in Ohio, to tell us what's happening in her state. Bev?
Hi, thanks, Lori. So in Ohio, we have obviously been under restriction, just like all of you. And we have heard the voices get louder and louder as businesses have been reopening. Of course, families are thinking, you know, staff are out there getting exposed, and so why can't I go visit my mother? I'm going to just talk briefly first about end of life and compassionate care and some changes that we made based on some stakeholder input and concerns that we were having. We actually, I got some language from a Kentucky governor, the Kentucky governor, and something that I had seen written from the state ombudsman there that specifically said that facilities should not wait for active dying. So using that, then we added that to our health department order and said, and it's similar to Kentucky, says that providers should notify families several days and up to 1 week in advance and should not wait until active dying. And then we added some indications of end of life, include the following: loss of appetite, no eating or drinking, increased sleeping, delirium, unexplained agitation, mottling of skin, significant decline in cognition, or an increase in depression accompanying other indications. So that has been helpful. I think we're still kind of trying that out. We use it when we have these concerns raised by family members. We're going to define compassionate visits in the order, but decided not to. That was actually my suggestion, that we not do that, because each time something happened with, my screen just disappeared. Are we still good?
We are still good, and keep going, Bevan.
Okay.
I will pull up to share my screen.
Okay, great. I just got a note saying somebody's internet went out. Okay, each time after the end of life order, the restriction and the allowance for end of life visits, each time the health department tried to make a change, or clarify, excuse me, each time they tried to clarify a question, it seemed to get worse. You know, then facilities would say, well, now it's more narrowly defined and that wasn't the intent of the health department. So I just didn't want to introduce yet another term that then people were going to start interpreting individually and weren't clear. So I do have an example, though, where an ombudsman did a great job advocating for a family member who contacted me just on this past week and said that she started with the governor, I guess, and got to me. She said that her mom had some knee surgery before she went into the nursing home. She had taken her to the doctor 26 times in 13 weeks. And now that she was in the nursing home, she wasn't able to take her to the doctor, but she has dementia and she knows how to help her mom at the doctor visit. So the ombudsman did an excellent job of advocating, wrote a letter to the facility, even suggested that they not limit the daughter's plan to stop for lunch, going through a drive-through. She outlined how she was going to keep her mom safe, went through a drive-through for lunch, and then stopped for ice cream after the visit, which actually was all happening today. So I'm hoping that it all worked out as planned, but the facility allowed that. So it was really just some great advocacy on behalf of the ombudsman. And then we had another situation related to end of life, where a facility, the things that they were saying just weren't really common sense. One son went in to visit mom who the facility had said was at end of life. They called the two sons in. They weren't initially allowing them to visit together. They said, well, we want to slow down the spread. We don't want them bringing it in. And I said, well, if somebody's going to bring it in, one of those two or both of them, it doesn't matter whether they are there together or there separately. So they ended up being able to visit together. I haven't gotten an update in the last couple of days on how things are going, if the visits are continuing, but it's just facilities are interpreting everything so narrowly, and so their individual interpretations are difficult. With regard to reopening, on the screen here you see a couple of things. On the left is Responsible Restart Ohio branded tool. It's a fact sheet, and that was put in place when the order was revised for this end of life change, as well as allowing outdoor visitation for assisted living facilities. That began on June 8th and has continued. We're hearing good things in terms of residents are very happy to see their families. The families are happy to see their loved ones, but we are also getting complaints about the condition that their loved ones are in. So I talked to someone yesterday whose mom had apparently not had good personal hygiene for quite some time. She was very worried about it, upset about it. So we are, I believe, going to be getting some complaints. related to people being reunited and what they're seeing. Some facilities are putting out tents so they can continue visits if it rains or if the sun is too hot. So I thought that was very forward thinking. Some facilities are being very limiting on their visits, like only during business hours. That isn't family friendly at all. Some are, we heard about one facility that was tying visit schedules to the work schedule of the facility receptionist, who was the screener apparently, and managing the scheduling of the visit. So that also doesn't work. But then we saw some facilities add staff to be able to help with visits. The photo in the middle of the page is one of our ombudsmen, Jimmy Gillespie, who's an excellent ombudsman for us in Ohio. He kind of was a trailblazer on video visits as he would ask a staff member to walk him through the building so he could make observations with an iPad, for example. Talking with residents, they have a great video of him having a good conversation by FaceTime, I think it was, with a resident. So he, not surprisingly, was the first ombudsman and his program director, Bob Vines, who reached out to some assisted living facilities. And this one, for example, said, hey, let's give you an ombudsman table. And so this facility did a great job of sending information out to residents and said the ombudsman is going to be here on this day during these hours for those residents who could like schedule a time. So they scheduled them in 15-minute increments, and they gave the resident a little slip of paper to remember what their time was, and then they would go out and visit. And a couple of those residents made notes about what they wanted to talk with the ombudsman about. The ombudsman developed or put together this plexiglass divider, which is actually a little hard to see, but the good thing is that it's really unobtrusive. Hand sanitizer on both sides, everybody wearing masks, and it was really helpful. And those residents who either didn't have time or couldn't get out to visit, the facility gave them envelopes and a piece of paper, and the residents could write notes to the ombudsman. So he got several of those. They were sealed, and so they were delivered to him when he was there. And every resident, he talked to 10 people, every resident gave him at least one complaint when he was there. And then those several envelopes were also included complaints. So we're very pleased with this. Obviously, that was a very cooperative and proactive provider. And I expect that you know, not all of them will be that way, but we have some more. Jimmy has some more scheduled for next week. And so I think this is a great example of actually facilities. We're hearing from a lot of facilities who really want to open up and want to bring in hairstylists, for example. We've been getting petitions from some assisted living facilities about hairstylists being allowed in. So I think that we're making progress, and our next step, I believe, will be outdoor visits in nursing homes. We don't have the timing yet, but our governor has said that he will make an announcement next week about what that timing will be. And then we need to think about what will be the next phase for assisted living. My recommendation is indoor visits, maybe in a single place before we do indoor visits just throughout the facility and in individual resident rooms. But we'll see. We're working on phasing. And I did also want to mention that Ohio is considering the CMS recommendations, the phases of opening up. We are considering them as they're written as recommendations, and Ohio is proceeding the way Ohio needs to proceed based on all of the input that we're getting. We have people who have contacted the governor on his personal email and cell phone. And so he's very involved, and those end up coming to me so we can work on resolution of individual problems. But the voices are very loud and very clear about wanting to reunite families and residents. Thank you.
Thanks so much, Bev. And thanks for bearing with us, everyone, as we had a little bit of technical issue, and we're going to try and keep it going. I'm going to try to move on to Suzanne Messenger, who is the state ombudsman from West Virginia. So Suzanne?
Thanks, Lori. It's so interesting while we're all in this business for the same thing, because we really want life to be better for our long-term care residents. Each state is experiencing this event in a different way. So I thought I'd just start out with a quick overview of what it looks like for me here in West Virginia. We have about 123 nursing homes. 14 of them had COVID cases, staff and residents. Statewide, we've only had about 2,700 cases, and that's the whole population. 233 of those were nursing home residents, and 167 were nursing home staff. Statewide, we've lost 92 West Virginians. 43 of those were nursing home residents, which is about 47%. We have not lost any nursing home staff due to death from the virus. Next slide, please. Just like other states, we've been doing lots of things. Our governor restricted visits at nursing homes on March 12th. And then we've kind of been struggling along, trying to do virtual visits and some alternative contact for our residents. And then June 11th, rather abruptly actually, the governor announced that starting June 17th, which was last Wednesday, visitation could resume at nursing homes that had no cases of the virus for 14 days, starting June 3rd. Next slide, please. So in West Virginia, we used the recommendations from CMS, as Bev mentioned, as recommendations, and West Virginia created its own recommendations for facilities. It is generally a three-phased process for what we call reopening nursing facilities: red, yellow, green. All of our facilities started in red, and then they had to ask permission from the licensing agency to move to the next phase. You'll see that red is the most restrictive. Next slide, please. Yellow is where about half of our facilities moved to either last Wednesday or gradually since last Wednesday. It is slightly less restrictive than the red phase. Facilities have a ton of discretion about how they're going to implement the changes based on their staffing, based on the presence of the virus either in the facility or in the community. Right now, facilities are allowed, residents are allowed to have visitors no more than 2 at a time. It has to be by appointment only. The facility gets to decide where those visits take place. Most of the visits are taking place outside, but we do have a couple of nursing homes that are allowing in-person visits in a common area, either a lobby or a office that has been repurposed for visitation. No visits that I am aware of are taking place in resident rooms. All the visits are time limited, anywhere from only 15 minutes up to an hour. No visitors can be under the age of 12, and everybody has to practice social distancing, good hand hygiene, and wear face coverings. Next slide, please. Communal dining is allowed, sort of, kind of, as long as they can maintain social distancing, and the residents have to practice good hand hygiene and wear face coverings to and from. A little bit of group activities are allowed, once again with social distancing. Interestingly enough, there actually is a staffing ratio for group activities, and the facility gets to decide where they're happening. And as Bev mentioned, our nursing home residents really value the services their beauticians and manicurists provide So facilities are allowed to let the beauticians and manicurists in when they're in phase yellow, as long as those professionals can comply with the other requirements that apply to any licensed beautician and manicurist here in West Virginia. Next slide, please. So once a facility is in phase yellow for 2 weeks and hasn't experienced another positive case and there's no substantial community spread, the restrictions relax a tiny bit. And the tiny bit is highlighted here in green. Basically, now the number and age of visitors is allowed to be determined by the facility rather than prescribed as only 2 visitors all over the age of 12. And for non-essential personnel, they are allowed in the facility in the green phase. Under the yellow phase, it was up to the facility to decide whether they wanted to permit them. Next slide, please. And there's no change for communal dining, group activities, or salon services. And keep in mind, this is the best it gets. This is the green phase. And the next slide, please. We do have a blue phase, which is really more, think of it like an emergency truck runoff on if you're traveling down the interstate. As facilities are moving between the red, yellow, green phases, if they do get some positives or there's community spread, they're not required to go all the way back to red. However, what happens in the blue phase is basically there's no out of the building visitors that are allowed in, only under the compassionate care exception. Next slide, please. But they can go ahead with some limited communal dining and limited group activities and still have limited beauticians. Next slide, please. So we've kind of sort of opened up here in West Virginia a little bit. Some of the challenges that we're facing are some of the same ones that Bev mentioned. Here in West Virginia, the definition of compassionate care has been interpreted extremely strict. And the only compassionate care visits that I am aware of that have happened have been for residents who are in the active stages of dying. There's lots of problems with that. One, how do we know? And two, compassion is much broader than just end-of-life care. So we have been advocating for a more open definition of compassionate care, really to be based on the residents, the specific resident involved, their individual needs, and the impact that no visits or no contact has had. That is still a work in progress here in West Virginia, and we're hopeful that the FAQs that Lori's going to talk about soon will help us accomplish our goal of getting a more compassionate care definition. When we're looking at success, it's important to look at it as resident advocates from the perspective of the resident. And if you just look at it from the process perspective, for whether the I's are dotted and the T's are crossed, generally here in West Virginia, the process has worked the way it was designed on paper. We aren't hearing a lot of problems. We do have a couple gaps in our process. Right now, we don't have a statewide definition of what community spread is, and that's caused some challenges. But those things can be negotiated, and you can consult with experts, and the process itself can be tweaked to work more smoothly. But the impact of reopening has been a bit of a mixed bag. While our residents have been very glad to get out of their rooms, many of them have been confined to their rooms for the last 90 days. So just the fact that their room doors were open was a good thing. But also many of them remember visits that happened in February and January. And if you look at the prescriptions for visits now in West Virginia, they're not really visits. They're more like viewings where people can look at one another. Now, granted, you can talk with one another and be in the same 6-foot space, but it is not a visit. In Appalachia, we are huggers. We are physical. It was not uncommon before this happened to see people in Walmart hugging one another as way of greeting, or hugging total strangers. I've hugged a flea market vendor before that I didn't know, and I do not know their name, but just because she was nice when I passed her on my way while we walked, that was common. That doesn't happen anymore. And now all of a sudden we've had to have ethical dilemmas related to hugging. And how do we accommodate hugs in this new environment? So I guess our final challenge is life versus safety. While we can't deny the ferocious impact of this virus, and even in West Virginia, we've been spared the consequences of some other states, but it's hit here. 47% of our deaths have been nursing home residents, and so we know, our head knows, we have to keep our residents safe. But how do we accommodate our heart and allow our residents to still have a life while they're being safe? And I think, just like all of you, that's our biggest challenge here in West Virginia. How can we move forward safely and help our residents not only survive this virus, but help them thrive during it? Thank you.
Thanks so much, Suzanne and Bev, for hearing about the things going on in your states and the great advocacy that you both are doing on behalf of the residents. This has been exceptionally difficult for everyone, particularly the inability of residents and families to be together. And we've been dealing with that for quite a long time now, as both of you have talked about. And we have, obviously, as Bev said, and I think as we've been seeing also, there continues to be a rising cry among family members for the reopening in nursing homes and the ability to visit with their loved ones. As our communities are opening, I think it's just making sense that people want to be going out again and seeing their loved ones in long-term care facilities. But at the same time, the amount of time that people have been separated and the impact on the residents has been tremendous. And so we really do need to find a way to get to where we can have safe visits where people can be together again. So you may recall a couple weeks ago, CMS had issued some reopening or visitation guidance. We talked about that on one of the previous webinars, and while I'm not going to go over it in any detail, you'll recall that there are 3 phases of reopening. Phases 1 and 2, it's very restricted. There's almost no difference between the 2 phases, and once you get into phase 3, more visitation is allowed. But essentially, most of the facilities across the country are in phase 1 and phase 2, where we're still looking at very much restricted access to residents. The guidance also talked about a number of factors that should be looked at before the reopening decision-making was going to be taking place, that to be thinking about some of these things, like what the case status was in the community as well as in the nursing home, what the staffing looked like in the nursing home itself, ensuring that there were no contingency staffing plans or shortages, which certainly we know there are issues related to that in terms of the staffing levels that exist in normal times in nursing homes. But that is one of the factors. Also, adequate testing, the availability of it, having a plan for testing residents and staff, the availability of face masks and other personal protective equipment is important, and the ability of having universal source control. What they mean by that is implementing precautions, hand washing, social distancing, and then also the hospital capacity in the area in which the nursing home exists. So that is certainly one of a set of the factors. So there have been a lot of questions about the reopening, how it's being implemented, how it should be implemented in the states, including related to compassionate care. That is one of the issues that has, I think, caused the greatest amount of angst among people, particularly as we've been seeing the, I think the lack of consistency about how it's being interpreted and implemented across the country. So CMS issued an additional set of frequently asked questions, just a handful of them, earlier this week, where it provided a little bit more information in a number of different areas. So for example, it talked about while they still said that facilities really should not broadly reopening visitation except for phase 3, there should be some creative means, or encouraging facilities to take creative means of connecting residents and families, and the outside visits is an example of that. The window visits is another example that we've been seeing across the country, and we know that that has been challenging in some areas as well. But there can be ways that people can safely come together again, and be able to put eyes on each other, to be able to talk, to see how each other are doing. Certainly the frequently asked questions, the guidance that CMS is providing really does promote screening and precautions in all instances, that there be cleaning and disinfection of any areas that are being opened up to visitation, and limits to the number and size of visits and the numbers of individuals visiting any one resident at any particular time, that there should still be limits on the number of people that are available, so that the capacity does not exceed what is safe for that particular area. But I think as we go through some of these different elements that are talked about as part of the frequently asked questions, I think one thing that it's really showing us is there need to be some good thinking about how these practices can be put into place, and also to have some good policies for that, and that they should be looked at in conjunction with residents and families, not just randomly made available and no one ever looks at them again, or they're not being monitored by even the licensing agency. So anyway, facilities are encouraged to establish some creative means of connecting residents and families. CMS also talked about communal activities, that for residents and facilities without COVID, that there is, they should be making available, or they could be making available the opportunity to have eating in the same dining room, or communal dining with some social distancing, which looks at limiting people at the tables, spreading the tables out. So that would limit the number of people that could be in a dining room at any one time. And also for group activities, that they can be done by incorporating social distancing, and by putting into place some of the precautions that we have been talking about. They're pretty clear in the guidance that this should be for facilities and residents that either do not have COVID, where there is not the existence of it, or who have recovered from COVID. But if for residents where they currently have tested positive or are showing symptoms of COVID, CMS is recommending that those residents still be kept in isolation and treated as part of the infection prevention precautions, or infection precautions in the facility, and that these communal activities only be made available for the residents who do not have COVID. As I mentioned, the compassionate care is an area that we are continuing to find challenging. While CMS does provide some additional language with respect to the guidance, I think it still doesn't go far enough. And I think that we have concerns about some of how they're interpreting it versus what we should think we should be incorporating. So for example, while we're glad to see that CMS does say that it does not exclusively refer to end-of-life situations, it is talking about, and the guidance does talk about it being just maybe on a limited basis, maybe even just one-time visits. It doesn't actually say that, but what CMS says is it shouldn't be routine, that it should be on a limited basis. I think that when we were looking at compassionate care, what we were really hoping to see here is that it would be really established as part of a person-centered process, and that we would be looking at what the residents' needs are, having the facility and the family be working together to establish what was in the best interest of the residents, and establishing a process that would be more in line with meeting the needs of the residents who needed compassionate care, either at the end of life or because they were experiencing significant decline or distress. The guidance talks about encouraging consultation with state leadership and families and ombudsmen and determining whether compassionate care should be allowed. It obviously talks about screening and precautions, and that maybe safe spaces within the facility should be established for some of the visits, and that appointment times and limiting the number of visitors in the facility at one time are things that the facility should consider. Again, while these things are guidance, I think the point is that it should be based on a person-centered practice. And actually, in a conversation that I had with CMS the other day, they did talk about person-centeredness with respect to compassionate care. I don't see it being reflected in these FAQs. And so that is something that we'll be continuing to advocate for. A couple other things that were discussed in the FAQs, and I see that we're coming to the top of the hour, but we're going to keep going if you'll stay with us for a little bit longer so that we can get through these and finish the program for today. So thanks for your patience with that. But a couple other areas that were talked about in the frequently asked questions were access to the Ombudsman program. The guidance clarified that residents do have the right to access to the Ombudsman, even if it's not in person, because of some of the restrictions with respect to visitation, that facilities must make access to the Ombudsman program available to residents. So that is something that is should be very proactive, and something the residents have the right to, and should be worked out so that the residents can talk with ombudsmen or do video conferencing with them or somehow communicate with them should they need ombudsman services. And then also the other piece with respect to the FAQs was related to discharge waivers. There were questions about the waivers that had been put into place with respect to the rights of residents who were being moved as part of the cohorting. And CMS clarified in these FAQs that the waivers that have been put into place apply only to the cohorting to prevent the spread of the COVID-19 disease, that any other discharge facilities must comply with all of the discharge requirements that are currently part of the regulations, including notification of the discharge, reasons for the discharge, and they need to be provided in a manner and a language that the resident and their representative understands. So we have talked about the discharge waivers on a couple different webinars in the past. So if you want some more information about that, you can look at the previous slides or re-listen to the recordings on the webinars. So I'm going to turn over to Mike Dark now, who is a staff attorney at California Advocates for Nursing Home Reform, who's going to talk to us about a social media campaign around the issue of visitation and reuniting residents and families, and some plans that Canner has taken to focus on this issue in the coming week. So Mike, I'll turn it over to you.
Thanks for that, Lori. At Canner, we are pushing very hard at the California state level to restore limited and careful visitation, but mandatory visitation for reasons that I'll get into quickly. The sort of game plan is that on June 29th, we are hosting a press conference where we will be facilitating, having families of several residents and some residents speak out to the press about the effect of some of these restrictions on their lives and on the care that they are receiving. And then on June 30th, we are hosting a social media event where we are encouraging residents, their families, advocates to reach out, email, tweet, Seema Verma of CMS and of others at the state government level. And this is all being coordinated through our platform called visitationsaveslives.com. But for this call, and I'll try to keep this tight, I wanted to spend just a few minutes explaining why we think visitation, even mandatory visitation, is so important against the backdrop that we are currently seeing of this surge in the virus, and why it is that we think visitation is actually an aid to resident safety, notwithstanding the concerns about contagion. And it's an aid to resident safety even more now in California during the crisis caused by the pandemic. And in California, anyway, it's really helpful to start with the understanding that, before the pandemic hit, California nursing homes had a huge crisis in understaffing, where you had CNAs trying to see 10 or 12 or 15 residents an hour for, medication and for bathing and for feeding and for hydration, much less for hand washing, right? And that understaffing really set the stage for the spread of the virus once it came to our shores. But crucially, it also meant that family visitors were delivering care. And so it's not just that they were providing emotional support, which, as we all know, is so crucial, but they were doing things like brushing teeth, making sure that bed linens were changed, making sure that people had been moved so they're not developing bed sores that go through to the bone. And so that's a really important and significant element of sort of the cost-benefit analysis that we're all trying to engage in thinking more about visitation now during the pandemic. But it also means that even before COVID, visitors were actually not very popular with nursing home operators and managers in California. They provided an additional layer of advocacy and oversight that mostly they didn't like. And one of the things I'll touch on very briefly, in terms of looking at the current visitation guidelines, is that when you have permissive guidelines, recommendations that nursing homes consider or that they are encouraged to permit visitors, in California, at least, the default will be to not let visitors in if they may not let visitors in. And that's one problem that we are having in the state with some of the language in the guidelines that we are seeing. And so just to fast forward a little bit, in March, we saw the restrictions rolled out at both federal CMS level, with the states following suit. And of course, the intentions were very good. It made sense. The concern was that visitors would bring the virus into these very vulnerable populations. We knew then, though, that restriction could also itself have terrible consequences for the health of residents, because there weren't going to be people coming in providing that care and providing that additional layer of oversight, especially at a time when federal, state and county health inspections had been so vastly ratcheted back. Those visitors were the eyes on the ground, were going to be the eyes on the ground that to fill in the gap that the regulators had left. Now, the problem that we've reached in California is that the restrictions didn't work to keep the virus out. We know officially the tally is certainly way more than half of nursing homes in California have seen the virus, have had the virus in healthcare workers and residents. It's probably more like 2/3. It's probably going to reach nearly all by the time we head into the fall. And so from our perspective at Cantor, the cost-benefit analysis has really been altered. The virus is there. You're not keeping it out with the restrictions on visitors, but worse, conditions have grown apocalyptic in California nursing homes with the lack of visitation. And this isn't just the result of COVID, it's the result of the lack of oversight, lack of staffing. We saw recently in Pasadena, the Golden Cross nursing home evacuated by the National Guard, not because of COVID, but because conditions internally had grown so dire in the absence of any outside eyes to see just how bad things were getting. So in our view, restoring visitation has to be careful, but it has to happen on a mandatory basis. And that's because these permissive rules simply leave too much room for nursing homes to say no. And similarly, if you're looking even at the CMS guidance, for 28 days without a virus, in a scenario like we have in California where the virus is so widespread, if you're waiting 28 days to go by without having any new instances of the virus, you may be waiting a very long time, maybe years, before visitation would be restored, especially if you add into that the CMS suggestion that it also wait until staffing is adequate, because staffing has never been adequate in California. So our take is that visitation doesn't just improve morale, it saves lives. And that is why, using that visitationsaveslives.com website, we are putting up pictures, stories of residents, of the effect of the restrictions, giving direction on how people can email or tweet suggested messages, political figures, regulatory figures who we would like to sort of have targeted for that messaging. It is our sense that California Department of Public Health is maybe moving towards some softening along the lines we've heard some other speakers talk about. For example, maybe towards outside visitation. The problem, of course, with outside visitation is it's only possible if you have an outside, which may not be the case in many, especially inner urban nursing facilities. But it also doesn't work for residents who are medically unstable or unable to get outside if they literally can't be moved. And it's those residents who most need that layer of additional oversight that visitors provide. The one thing that is kind of a ray of hope for us is that we are starting to see in some quarters, especially with assisted living, an unexpected appetite on the part of the facilities to have visitors come back. I'd like to think it's just because they care about the residents, but it is also because they understand from a business perspective, families and potential future residents just don't want to go into long-term care if it means essentially being stranded on a desert island for the foreseeable future. So we're optimistic that things will change. It has to be careful change, and we encourage people to check out that site, visitationsaveslives.com. Thanks so much, Lori.
Thanks so much, Mike, for coming on and talking about that. Consumer Voice is going to be joining California Advocates for Nursing Home Reform next week as part of getting the word out about the need for reuniting residents and families, about establishing visitation practices, and we'll also be sharing some additional information with you all early next week as well, and hope that you all will participate in this also moving forward. So with that, we're at the end of presentations today. I'd like to remind you that you can find more information about all of the things that we talked about today on the Consumer Voices website, but also on our partner websites, Long-Term Care Community Coalition, Center for Medicare Advocacy and Justice and Aging, and also at California Advocates for Nursing Home Reform. You can find information about all of the things we talked about today, as well as the recordings for the previous webinars. And once this webinar is completed, we'll be posting the slides and the recording of this one as well. Also a reminder that we are asking you to share your stories. There is a link on the Consumer Voice site on the COVID pages where you can share your story and information about your experiences during this time period. So we would encourage you to do that. I think we're well past our time today, so unfortunately we're not going to have time for questions, but do thank you for joining us. We will not be having a webinar next week. We're at the 4th of July holiday, so we will not be holding a webinar next week, but look for additional information about future programming as we all work together to plan ways that we can continue to provide you with the information that you need to advocate for residents during this time period. So thanks so much for joining us today. Enjoy your weekend and stay safe.